The human orbit is often described as a socket for the eye, but its clinical reality is that of a rigid, unforgiving bony vault. Inside this vault, there is no room for expansion. The volume of the eye and its supporting tissues already fills the space to capacity, making the entire structure highly sensitive to even minor pressure variations. This space is bordered by rigid bone on every side except for the anterior opening, which remains the only direction for potential displacement. Covering this anterior opening is the orbital septum. It is a thin but critical fibrous firewall separating the external environment from deep internal structures. This septum defines two distinct clinical zones: the superficial preseptal space in front and the deep retroseptal space behind. Because the orbit is a closed system, any added volume, whether it is inflammatory fluid from an infection or a sudden mechanical force, results in highly predictable clinical signs. Since the bony walls cannot move, the direction and nature of a patient's symptoms are determined entirely by which side of the septal firewall the pathology is on. We see this anatomical logic in action with infections localized strictly anterior to the orbital septum. These superficial infections typically follow skin trauma, such as an insect bite or a laceration, which introduces Staphylococcus aureus or Streptococcus pyogenes into the tissue. In this cross-section, we see the resulting presentation. The infection causes a unilateral, tender, and red lid. While the periorbital edema looks severe, the glowing septal line keeps the inflammation from migrating into the deep orbit. The most critical step in confirming this diagnosis is verifying what is not occurring within the eye itself. Because the retroseptal space is untouched, there is no internal mass effect and no pressure on the vital structures. Consequently, while the lids may be swollen, proptosis and chymosis are absent. Visual acuity is unimpaired, pupillary reactions remain normal, and ocular motility is fully intact. As long as the septum remains unbreached, the infection can be managed in an outpatient setting using oral coamoxiclav. The situation becomes a life-threatening emergency when the infection moves behind the septum, a condition known as bacterial orbital cellulitis. While this can happen via hematogenous spread, the most common pathway in children and young adults is the invasion of infection from adjacent structures. This axial view shows the breach. Bacteria from the ethmoid sinuses break through the thin medial wall of the orbit, directly entering the retroseptal space. Once inside, inflammatory fluid and pus rapidly fill the rigid cavity, and because the bone cannot give way, pressure rises. This internal mass effect physically shoves the globe forward and away a infection site, most commonly in a lateral and downward direction. This outward displacement, or proptosis, is a cardinal sign of the disease, though it can be easily hidden by the severe swelling of the eyelids. As the inflammation spreads through the compartment, it infiltrates the extraocular muscles themselves. This leads to painful ophthalmoplegia, a state where any attempted movement of the eye causes severe pain and is physically restricted. The ultimate danger of this rising pressure is the compression of the optic nerve, which can lead to rapid visual impairment and pupillary dysfunction. Orbital cellulitis is both a toxic invasion and a mechanical crisis, an acute compartment syndrome where the confined anatomy of the orbit directly threatens the vision. If the retroseptal infection is not controlled, the pathology extends beyond the orbit. Local expansion can create a subperiosteal abscess, which typically develops along the medial orbital wall. However, the most dangerous trajectory is backward. The venous drainage of the orbit provides a direct path for the infection to travel from the orbital veins into the cavernous sinus at the base of the brain. This can lead to cavernous sinus thrombosis, a catastrophic complication with a high mortality rate. Clinicians look for specific indicators of this spread, including bilateral involvement, rapid progression of proptosis, and congested facial and retinal veins. Systemically, the patient will show signs of severe illness, including prostration, headache, nausea, and vomiting. Management requires immediate hospital admission and the administration of intravenous antibiotics, such as ceftazidime and metronidazole. Given the direct vascular connection to the brain, medical teams must monitor optic nerve function every 4 hours. Changes in visual acuity or pupillary reaction are the primary indicators that emergency surgical drainage is required. While infection adds volume to the orbit, trauma manages the same space through a different mechanical failure. A blowout fracture occurs when an object larger than the orbital opening, like a fist, strikes the eye with significant force. Because the object cannot enter the bony rim, the globe itself absorbs the kinetic energy, driving the soft tissues backward into the socket. This creates a sudden, massive spike in intraorbital pressure. In this coronal view, we see that pressure waves slamming into the weakest part of the architecture. The structure fails at its thinnest point, the orbital floor, specifically the bone covering the infraorbital canal. This specific point of failure immediately involves the infraorbital nerve. The damage causes anesthesia across the lower lid, cheek, nose, and upper gums. As the floor gives way, orbital contents herniate downward. Soft tissues and the inferior extraocular muscles drop through the fracture into the maxillary sinus below. With the loss of supporting volume below, the globe sinks backward and drops downward, a condition called anophthalmos. If the eye muscles become physically trapped in the shattered bone, the patient will experience double vision, or diplopia, which is monitored clinically using a Hess test. Initial treatment is conservative, using ice and decongestants. Crucially, patients are instructed not to blow their nose, as pressure could force bacteria directly into the orbital cavity. Surgery is reserved for correcting persistent diplopia or significant anophthalmos. Whether the cause is a bacterial breach or a mechanical strike, every orbital emergency is defined by the same spatial constraints. These two pathologies represent opposite sides of the same mechanical coin. When volume is added behind the eye, the resulting pressure pushes the globe out and threatens the central optic nerve. When the floor fails, volume is lost, dropping the eye and trapping the peripheral nerves and muscles. The clinical presentation, whether it is proptosis, ophthalmoplegia, or anesthesia, is a direct result of how these anatomical boundaries have been compromised. By identifying whether the septal wall or the bony floor failed, medical teams can determine whether the condition requires routine antibiotics or immediate surgical intervention.